Hello, and welcome to Conversations with Charley. Today, joining me is Celeste Vaughan-Briggs, who is a lifelong resident of the greater Philadelphia area. She earned her undergraduate degree in psychology from Temple University and her Master of Social Work from the University of Pennsylvania. Celeste is a licensed clinical social worker with more than 28 years' experience. She is currently an oncology social worker and a program manager of a cancer screening program, as well as an adjunct faculty member for Temple University School of Social Work. Over the years, she has worked with individuals, families, and communities impacted by interpersonal and community violence, sexual assault, and other physical and mental health issues. Her focus and passion are serving the uninsured and medically underserved, providing trauma informed care and advocacy. Today, we will address health disparities for marginalized individuals and communities. Welcome, Celeste.
Hi, glad to be here.
I am happy to have you. So let's get to it. Walk me through this topic of health disparities.
Well, first of all, thank you for having me on. I'm very passionate about this topic. So when I start to talk about it, first let's talk about and define what are disparities.
Absolutely.
There are lots of different ways to think about it, but according to the National Institutes of Health and some other major organizations, they define it as persistent differences in health conditions and illness rates that cut across many different illness categories and demographic groups. So at its essence, different health outcomes, different illness rates among different types of people.
Okay.
Now that, on its surface, doesn't seem like it's that bad. It's just differences.
Right.
But what ends up happening is that these differences can lead to poor health outcomes, unequal access to care. It can also lead to premature death or injury that's not treated the same, worse health outcomes based on these factors. These factors can be along racial lines.
Okay.
These factors can be along gender identity or sexual orientation. These differences can be geographical.
Okay.
And we think about urban versus rural. So there can be lots of different ways that we can think about disparate care. But at the bottom line, it really impacts individuals, families, and communities, with everybody not getting the best care that they can get for their situation.
So you mentioned access. So tell me, how can access be a health disparity?
So when we think about going to the doctor, I break my foot and I need to go to the doctor. Well, if you're in a community like Philadelphia, where, wow, there's all these different healthcare institutions, but you don't have a car, that's going to impact how quickly you can get there, knowing that ambulances now, there is a charge. Do you have health insurance to get seen in an emergent setting? So right there, you have a human thing happen, you fall, you break your foot, you break your leg, and right off the bat, there's going to be different levels of services that you can get based on some factors that some are really beyond your control, a few may be in your control.
Wow, that's interesting that you said that. I mean, you said a number of things. One, access. I asked you about access, and as it relates to health disparity, you mentioned the location of a health facility and whether or not you have a car, and then you mentioned the financial piece. If you get picked up or by an ambulance, there's a charge. So, it could create debt for you. And then you have to make the decision whether you call an ambulance to get health care or not because of the money, what you'll be charged in the long run. And so you have to make decisions on the spot about getting the care that you need, which is really interesting.
And it's very insidious in the fact that it kind of, these big and small choices impact us in subtle ways and sometimes overt ways. We've seen this a lot with COVID,
Right.
where access to care and treatment, a lot of work was done to try to destigmatize as best as they could in communities getting tested and coming to get acute care. Some communities had better success than others, but part of the reason that there was a lot of kind of conversation in public health and social work and healthcare about trying to be clear, if you don't feel well, get tested and come to the hospital, because what you didn't want is the lack of access to have people continue to go and spread a communicable disease to beyond their immediate family and to the community, and then get sicker and sicker and not get a treatment that could potentially, save their life. So we saw this with COVID, but this can go for a number of different health issues: high blood pressure,
Absolutely.
diabetes, people not going to the ER when they're having a heart attack or think they may be having a stroke, people who have symptoms that, if treated early, can really forestall a lot of serious health issues, not just cancer, but think about diabetes, when somebody may be pre-diabetic and they're getting thirsty and all of these other things, but they don't have a regular healthcare provider that they can go to on a regular basis to get them on some medication and manage it, while it's just, a couple doctor's visits, a little bit of blood work, and maybe, a $40 prescription, versus, a serious long-term hospitalization where someone may, have some kind of amputation or have a stroke or something a lot more serious. So small problems can get very big when we think about disparities.
So let me ask you this. You think about an individual. So, this health disparities is huge, right? We will probably just barely scratch the surface today. But when you think about this, one, you have the mindset of the individual, right?
Yes.
It's just a cough. I don't need to see a doctor. Oh, it's just a, I stumped my toe, but the clot hasn't gone away. It'll go away. I'll drain it myself. Little simple things, right? You have a mindset of the individual. And then we have dealing with some of the healthcare facilities and providers and their biases. So we already have an individual issue as it comes to our own healthcare. And then you go into these facilities that already have their own biases about certain populations of people. One, how do we start to change the mindsets of individuals? And then once we've changed the mindsets of, or, we're changing the minds of others, when they get into these facilities, how do we help them navigate so that they get the best care that they can?
So that's a great point and a complex answer. So I'll try to break it down in a couple of different steps. There are a lot of folks looking at this now, but there have been a lot of folks looking at this issue for a long time. People both internal to the healthcare system and external folks who are studying these issues, advocacy groups, nonprofit organization, activists. There's a lot of people and a lot of people trying to figure out the answer to your question.
Right.
I want to bring up because you brought up bias, and bias is a very interesting concept. So human beings do have bias. Our brains categorize things and put things in groups to give us like a little shorthand to think through complex problems.
Right.
It doesn't necessarily have to be a malicious type of bias, but bias exists. But there are some biases that exist within interactions in professional spaces that have to be addressed. So in 2002, the Institute of Medicine of the National Academies released a landmark study that was actually commissioned, interestingly enough, by President Bush, called Unequal Treatment, Confronting Racial and Ethnic Disparities in Care.
Mm-hmm.
And this was one of the first recent studies that really kind of explored the impact of bias, provider bias,
Mm-hmm.
what happens to patients. Not just, oh, it's an issue of being uninsured or underinsured, or it's just an issue of geographic region, or it's just the issue of finances. In this study, they really did this huge meta-analysis, and they kind of sorted through some things and said, all things being equal, even when people have, equal insurance and equal levels of education and are presented with the similar type of diagnoses and options, that the bias of the healthcare provider in that clinical encounter may lead to disparities along racial, ethnic, and gender lines. They reproduced this as well to point out things with sexual and gender minorities too. But it really is kind of putting the onus and saying, listen, physicians, nurses, PAs, healthcare social workers, MAs, everybody, we're part of the problem. We have to look at this. Mm-hmm. It's the issue is still going on. That was in 2002. So what do we do now? So there's been a lot of folks in spaces kind of on the advocacy and activist space, kind of trying to push healthcare systems and providers to be more accountable, to work harder to reduce the negative impact of bias. Not saying that as human beings you're not going to have it, but like saying, okay, we're going to look at it, we're going to examine it, and we're going to try to address it and mitigate any negative factors that come from the bias, and try to give everybody the standard of care plus.
Yeah, so what does this standard of care look like? And you said plus, so I'm just going to start with the standard of care. What does that look like? Is that equal playing field? I mean, what does standard of care look like? What could one expect from that?
So what's interesting is for all diseases, now, of course, doctors argue amongst themselves, but for all diseases, doctors, researchers, epidemiologists, they get together and come up with our practice guidelines to say, in the best case scenario, based on the biological factors of this disease, this should happen first, this diagnostic test should happen. Okay, if that result leads to this, and this, let's say for a cancer example, if this cancer has these biological characteristics and it's of this size in a person of this age and this health status, then these are the recommended treatments, and that is standard of care.
Gotcha.
But what we found over and over again in cancer and other health disorders, and this happens in mental health too, is that providers make assumptions based on who's sitting before them, and they might not offer them standard of care. So what we're trying to do is get institutions and providers, some a little bit of a carrot and some a little bit of a stick, to say, okay, you have to at least follow these clinical guidelines as set out by your accrediting bodies, and that you should make all good efforts that all patients receive at least the standard of care.
So let me ask you this. So I'm an everyday person. I'm not, let me just say this. I don't have the background that you or a medical professional would, right? So for me, if you were saying, if I was going to the doctor and I said something like, well, what is the standard of care for this diagnosis? Is that something that would perhaps make that medical professional say, oh, let me make sure I follow what's required. Because sometimes it's about you don't know what you know until you know it, or you don't know what to ask until you know to ask it.
Yes.
And a lot of times, the elderly, people coming from other countries, they don't know the questions to ask. But if you had one question to ask, would that question be, what is the standard of care for this particular issue? What are your thoughts on that?
I think that's a good place to start. I think um, usually what I do is try to help people gather their thoughts, because when you're confronted with either an acute or a chronic illness, your mind's going everywhere.
Mm-hmm.
Sometimes your family members, they're asking you questions, you have questions. So the first thing I usually tell folks is to first take a breath,
Mm-hmm.
get a notebook, or however you like to, keep notes. If you like to talk into your phone, do that. But, writing it down is helpful, and start gathering your questions so that you can make the most of all the interactions that you have with your healthcare team. And then hopefully having a support person. I know sometimes with COVID, there's been restrictions on that. But do you have someone in your friends or family circle that does have a little bit more knowledge about a particular illness or the healthcare system, so that they can at least help you formulate your questions that you're bringing to the doctor, and then kind of taking it from there? But I think that is a good place to start. What is the standard of care for what I have? And
Right.
then asking them to explain it in layman's terms.
Sure.
Sometimes doctors, they've spent a lot of money on their degrees, and they like their medical language, and bless their hearts, that's wonderful. But it's absolutely okay to say, listen, can you please break that down for me and what that means?
Yeah. So, do you think saying something or asking something as simple as what is the standard of care could possibly reduce the health disparity that we see in patients?
It can start to open the door, because what you want to um, help acclimate your clinician to is that this is a partnership. They
Mm-hmm.
are the expert. They've gone to school. They have the medical knowledge and the training, but you are the expert on you.
Yeah.
And this needs to be an ongoing conversation. And we need to constantly be communicating with each other so that we can kind of sort through any assumptions that may block me, the patient, getting the best care available. Sometimes where this meets down to, I'll make another oncology example: access to clinical trials. And clinical trials can be a very challenging conversation for folks, because people have different understandings of what they are. But for many folks who have a very life-threatening or acute illness, um, you want your clinician, at least, because standard of care is to discuss any options or possibilities for you, you want them to at least bring that up, even if you, the individual, make an informed decision not to participate. The standard of care is that they should talk to you about that, not just assume because you're black or brown that, well, you feel some kind of way about clinical trials, so therefore I'm not going to bring it up to you, because that isn't the standard of care.
So,
And that, yeah.
let me ask you this. So, for my listeners out there, what are clinical trials?
Clinical trials are the way that we basically, doctors discover new treatments.
Okay.
Everything has to be tested, and I can only speak about this country, and I can speak to it as a person in the healthcare field, but not with a medical degree, so that's my caveat. But clinical trials are structured experiments. I know experiments, I'll put that in quotation marks, but they're trials. They are comparing different interventions. It can be a drug, it can be surgery, it can be vitamins,
Oh,
and its impact on a particular disease.
okay.
Once someone is enrolled in a trial, they usually talk to you just up and down about all the things involved in it. They have a specialized person they may be following you a little bit more closely. You may get additional lab works because they're going to check you up top to bottom to say, okay, we gave this person extra doses of vitamin C while they were going through radiation treatment for breast cancer, and we want to see, did that impact their or reduce their exposure to getting any kind of colds? And they will have the doctors will crunch the numbers and they'll look at all the people, and then they'll say, okay, based on this, our educated um, uh, guess or hypothesis is that in this dosage, taking this much vitamin C while you're going through radiation has a positive impact, blah, blah, blah. Like
Yeah,
everything went through a clinical trial.
absolutely.
Tylenol went through a clinical trial at some point, but
Sure.
we all take Tylenol without thinking about it now.
Yeah. Well, and it's, are you one of these, are you an early adopter in that you're willing to experiment with something like this? But I guess my question would be, how often is this conversation broached with a patient? I can't say that I've ever had, and perhaps I haven't had the need to, but or even heard of family members who I know have had significant health issues being approached with clinical trials. So when we talk about access, is this something that people of color um, would be asked to participate in generally?
And that's a good point. Um, there is that, and that's a little bit speaks to the disparity kind of generally that people have that may not so much be based on race, but it could be type of institution that you get your care from. Is it
Mm,
rural? Is it urban? Is it an academic medical center?
mm,
Is it a community hospital?
sure.
Um, and kind of that can be a disparity too, because maybe that smaller hospital doesn't have as many opportunities for those clinicians to even explore clinical trials or have the infrastructure or frankly personnel, because they have like special study nurses and things like that, people who really follow the patient. Maybe they don't have it ramped up in that area. So yeah, that can be disparate access along those lines. Some diseases or conditions may not have as many open clinical trials.
Sure.
Oncology is one of those areas. Cancer is one of those areas where a lot of attention and focus is on clinical trials
Yes.
because cancer is such a big issue and concern. There's a lot of attention on trying to kind of crack the code and figure out ways to make people either cure the cancer or stop the cancer from growing with minimal side effects and a good quality of life for folks who are impacted. So there's a lot, but there's other diseases, strokes and heart
Mm-hmm.
disease.
Yeah.
Yeah, and there's a lot of good stuff going on in the complementary space because I know a lot of people like their herbs and things like that, but there are some institutions that are trying to look at that a little bit more diligently. So maybe that's something that somebody would want to participate in and see, if that's going to impact their health positively. So sometimes we can seek out those things and present them to our medical team as well. And that's like kind of being your own self advocate.
Yeah.
You can do it on behalf of your loved ones if you know that they are having difficulty with a particular treatment. There's some good like one-stop shops to go to. There's actually a website called clinicaltrials.gov,
Oh,
which is a site that you can go to that's based at the governmental level, and it has a searchable database where you can type in the condition that you have, and it will pop up a lot of different solutions. They may be across the country, so that might not work for you, but at least that's one place to go.
so clinicaltrials.gov, G-O-V, correct?
Correct.
Oh, very nice. So, well, let me ask you this question. So, healthcare, right? Healthcare for everyone. Everyone gets healthcare. What are we doing about our uninsured? And are they getting the
Yes.
treatments that they need?
Yes. So we are better than where we were, but we have a long way to go, both in the United States and even globally, that people have access to the best treatment that they can. So in this country, we most recently, the last big stab at it that we had was the Affordable Care Act, otherwise known as Obamacare, which was passed in 2010 and has gone through several legal fights up to the Supreme Court, including the most recent one, which was called the Texas Hold'em case, which basically threatened to get rid of the Affordable Care Act. And the Affordable Care Act is two ways that folks, if you don't have insurance through your employer, that you can get insurance. One is if you make over a certain amount of money per month or per year, then you can buy it on this regulated site. It's still commercial insurance, but you can buy it and have a subsidy based on your income.
Okay.
If you make under that amount of money, then you can potentially be eligible for Medicaid, which is a state-based, means-tested form of insurance. Now, that depends on what state you're in, because some states have the ability, based on one of those earlier lawsuits, to opt out of expanding Medicaid for folks who are under that kind of threshold. But
so what you're saying is if you make depending on what state you're in, if you make a certain amount of money, you may not qualify for the state insurance?
Correct. Mm-hmm. For the state-based Medicaid. Mm-hmm. But there are usually local advocates and folks that people can connect up with to try to see, can you get care? Most hospitals have some form of what's called compassionate care or charity care, at least most nonprofit hospitals. For-profit hospitals don't have to opt into the same way for the rules, so it can be a little trickier.
So let me stop you there. You just said something that blew my mind, right? Mm-hmm. For-profit and nonprofit. How do you know where you are? How do you know what facility? You know what I mean? I'm at the hospital. As far as I'm concerned, it's all nonprofit, but that's not true.
Yeah, no, it's not true. And even to make it more complicated, you have something called safety net hospitals. The healthcare landscape is so complicated. So let me break it down like this. A for-profit hospital may be an institution that kind of follows certain rules and may be able to be more restrictive around what kind of insurance they take or don't take. They may have much more strict policies on what to do to collect medical debt. Not saying that nonprofit hospitals don't do that sometimes, but sometimes nonprofit hospitals can be a little bit more regulated. Not all, but many academic medical centers, like your big institutions that are usually associated with the medical school, many of them are not for profit, but not sure. Honestly, the only way that you look is if you're looking on their website, and you kind of sometimes have to go down to the fine print to say, is this a safety net hospital, which would treat anybody regardless of insurance status, and work to try to address any kind of bills through a variety of different means. Is it a not-for-profit hospital or is it a for-profit hospital?
Yeah. So what about folks who, there's no serious issue, or at least that they are aware of, and, it's about just getting regular checkups, regular physicals, regular dental, regular vision checkups. And, there's a disparity there because some folks aren't doing it because they don't have insurance, or they don't see the need because it's just kind of been programmed in their brains over the years, that, I don't need to go to the doctor. But, what do we say to these folks about getting the basic care, the basic follow-up? How do they do that, especially the ones who are uninsured?
Yeah. So what I try to do, a part of my role is to try to talk to folks about it, is look for the resources where they are. Most communities do have, not all, but many communities have a kind of, it's called federally qualified health centers or community health centers, which some of which provide um, access to dental care, but most often have your basic, like, access to a physical for themselves or for children, are able to get, kind of a script for, antibiotics, are able to see someone on a regular basis. In a city like Philadelphia, we actually have an abundance of federally qualified health centers, some of which will operate on a sliding scale, and some of which will actually, if you make under a certain amount of money, then it might be almost free to you to get some basic access to health care. And then they usually have financial counselors or patient navigators who can help walk you through. Could you be qualified for that Medicaid? And if you are, helping you to get that. So maybe if you do need something a little bit more extensive or expensive,
Yeah.
you can actually get access to it. But a lot of it too is a mindset. And that's part of what the ACA was trying to do many years ago. And I think we have an opportunity now with COVID too, is to say we never know what's going to happen tomorrow. Wouldn't it be better to try to see, do you have a regular insurance, get a regular physical, help try and find a doctor. If you don't know, talk to a family member or a friend and they can get you connected. And better to do things and address them while they're small and preventable, or at least not as large of an issue. And then it could be far less invasive and intrusive into your life than if you wait till the catastrophe befalls you.
Yeah. Yeah. I have a question for you. So, as it relates to this health disparity, if you had to tie this to making a change in your life, right? What is this something that you're in control of as it relates to health disparities? What could an individual or a health provider or a professional do to help folks stop tolerating some of these disparities that are surrounded around health and health care?
I think one of the first places to start is to appreciate your voice and your value and your gut and your thought, because many times when I'm talking to folks who I'm navigating the process of getting some cancer screening, many times it's because they felt something wasn't right. When we're talking about breast cancer screening, they felt their lump, or they just felt like something, just their body was different, and they sought the resource, even though they were scared, even though they didn't know how it was going to turn out. They either talked to a trusted friend or family member, or they just listened to that voice within themselves and they took the next step. So I think listening to yourself and then taking that next step to connect to, a service, a provider, to get or address the issue, even if you don't quite know what the issue is right then.
Sure.
And then continue to push and advocate for yourself. And a lot of times it really comes back to basics. Questions, writing down your questions, writing down their answers, asking folks to explain terms. All of those things will help you, the person, understand more what's going on with yourself, and being able to get that voice in your gut, in your head, to match up. If you think that a provider is being biased towards you, if you see them start bristling because you're asking a lot of questions, then maybe that's telling you you need to seek care elsewhere. And for providers, I think, is to be more open and to live in the tension of, yes, we know a lot, but nobody knows it all.
Right.
And to listen to the patients, because they are the experts in their own body. They might not know, the chemotherapy and what the expected, kind of feelings are, but they can tell you something's not right, and to really listen, because if you really listen, then you're going to have a better relationship with your patient, and the outcome is going to be better.
Yeah, I agree with you. Treating every patient like it's their first time there, like it's your first time, when you first start a job, you're taking extra care with everything that you do because you want to do it right. These are
Mm-hmm.
people's lives. They trust in medical professionals. They hang on every word. And speaking of every word, how intimidating is it to have a doctor run off some long medical term that you can't pronounce or spell, and then you ask them to spell it and they look at you like you're crazy, kind of dismissing the fact that you don't have the knowledge that they have, and the fact that you want to know more, and you want to be able to look it up, like you don't want to trust everything you find on Google, but you'd like to look up a term so you can at least educate yourself about
Exactly.
how it sounds, how it's spelled, what it means, and so that you can have a intelligent conversation.
And providers, there's no one, just like there's no one way to be a patient, there's no one way to be a provider. But I think, you know, we are moving into a different era, and there's things that have to change. How they have been trained. It's better, like I said. Sometimes you'll find the younger providers a little bit more open because their training has been different than maybe some of the older providers, where it was, I, the doctor, tell you the patient do X and Y, and you, the patient, don't ask me any follow-up questions. Some of the younger professionals, medical schools are trying to get better
Mm-hmm.
about really, handling that relationship, but there's still a lot of work to do.
A lot of
There's a
work to
lot
do.
of work to do. Yeah.
Absolutely. Hopefully, we have, we're bridging some of the gaps. I mean, as we're talking about biases and as we're talking about access, that we continue to get better in this country and abroad. And we need to change the mindset of the consumer, of the patient. And you only
Yes.
do that when they trust you, right?
Yes.
And
Yes.
so, if we want folks to be in better health, if we want the folks in this country, to take their health seriously, it begins with trust. They need to trust that they're not going to be judged, but they're going to be provided the same care as anyone who walks in the door, no matter of their color, race, gender.
Absolutely.
And so it's very important that we continue this conversation around health and healthcare. I thank you so much for joining me today. I think it's important for consumers to hear the information that you were talking about. Listen to your body, right? It's important
Yes.
to listen to your body and trust your gut, as you said, Celeste. If you don't take anything else away from, trust your gut and push,
Push.
push just because they're like, oh, I don't hear it, but it's there. It's there. Let's figure out another way because something's wrong. And so I
Absolutely.
love that. Thank you so much for joining me. I can't wait till we talk again. And to my listeners out there, I want to tell you to stay tuned for our next conversations with Charley, and we'll talk to you soon. Let's say goodbye, Celeste. Bye bye.
Bye bye.